is our 14th or 15th. I think we calculated over 3,000 people have viewed Dr. Joe's content. If you combine both those in attendance to the open forum, which we kind of renamed the open forum from open CO forum, and then the YouTube, last couple of YouTube posts have gotten over 400 views pretty quickly. So we're glad to share Dr. Joe's wisdom and information. We think he does as good a job as anybody because he's technically competent and he's just got good common sense and handicaps things well. And most of you know him. I think all of you do. It's good to see everybody. We before we turn it over to Joe, I do want to mention, Dr. Joe, that Ed Nicholson's going to help me facilitate this forum. And why don't you all share with each other? I'm going to step away to go to Northwest Arkansas Council meeting. And why don't you all, have some conversations with Ed, anything you want to talk about how your business is doing, ask others how they're dealing with it, and or share what you're doing to handle this COVID time if you'd like to, or if you want to. We don't have structured a guest speaker in that second part like we have in the past. And you can either chime in. Tommy Van Zant's on the call. He's always got some wisdom to share. We can talk about what the prospect for office space is. Matova mentioned in our Tech CO forum that or Movisa, excuse me, that they're going to lease half their space up in Bentonville because they're a tech company. They just don't need as much. So there's some of those kind of things to kick around, and lots of other things. Shannon may have some things to share on the consumer products and some of the consumer behavior there, or just what she sees, supply chain, if she'd like. With that, so Ed will take over by the time Joe wraps up, and we'll ask for questions. I may step away. We have 2 meetings of the Northwest Arkansas Council, so I feel like I need to be engaged there once 2 meetings a year, really, and apologize for that, but felt like I needed to do that. And so Dr. Joe Thompson, as we've always said, and we continue to be grateful for you coming on to share with us your knowledge and wisdom. And with that, we'll turn it over to you.
Thank you, Tim, for having me. And thanks all of you for being on with us today. We've got we've got a lot of information. We've got some obviously continued concerns, but we also have some good news, I think. So we'll jump into it. Michael Farrell is going to run for me today. Tim's got a substitute. I've got a substitute for Sandra too. If you can go forward, Michael, we'll go pretty quickly here. We're in the middle of all this. We continue to lead the world in the number of cases and also in the rate that we have. Comparing ourselves to Europe, actually Europe has lost a little ground. You may remember on the next slide Europe was about 4,000 per day last week, or 2 weeks ago. We were at 62,000 a week 2 weeks ago. So both of us are moving in the wrong direction, but there's still this huge gap between what they have achieved largely with masking compliance and their communities are able to fully function and are returning to normal. In the United States, we've now had over 139,000 reported deaths. And obviously the hotspots in Florida, Texas, Arizona are moving forward, but it's not just Florida, Texas, and Arizona, as the next slide shows. We've got many of our states that have uncontrolled spread across the United States. The Northeast is really the place that you want to be right now, not only because it's cooler, but also because it's got less viral load there. The Governor and Secretary Smith come out each day with our Arkansas County counts. We now have, we'll cross 7,000 active cases this afternoon, I'm sure. These counts actually, are important. I want to, commend you guys in Northwest Arkansas. You brought your rate down. On the next slide, you'll see the active cases per 1,000 residents by the trauma system. I like to use this because it's kind of the hospital referral network for Northwest Arkansas, North Central Arkansas, Jonesboro, Little Rock, Fort Smith, Hot Springs, and Pine Bluff. So this gives a little idea about the capacity or the active cases that are in the region that you have. We'll come back in a little bit to talk about testing. You know, we only know active cases if we test and we get positive. So some of the delays are really hurting us. This is what I want to commend y'all. You'll see your Northwest Arkansas rate has been trending downward. Most of the others are flat. We've got some concerns, obviously, down in the southwestern corner of the state. The UAMS forecast model came out yesterday, and here's the first bit of good news that I have for you. They reduced by 20% their estimated peak number of active infections and pushed that back to the end of October. Their peak number now expected it would be to have 112,000 active infections on October the 29th. ACHI also worked with the health department and put out city level rates of infection. And we did this for a couple of reasons. One is, you know, when they come out with the counties, that's largely weighted by population. So the largest population is going to have the most number of active cases. So this shows you actually that some of our smaller cities have some of the highest rates of cumulative infection. Now, these aren't active infection. This is total infections over time. And actually, I was somewhat surprised that when I've shared with y'all that I've been to the lake, my mom's community that has where she has a lake house that she lets me use every now and then. On the top, you can go one more. I think it's Higdon, Arkansas has 20% of their population of 122 people that have had COVID-19. So this is on our website now. On the next page, you go on our COVID-19 site and you can look up over 200 cities, what their positives number are cumulatively and what their rate is for people who reported that they were from those communities. We took the number of positives and we divided it by the population rate. There's probably a little, you know, if you're inside or outside the city limits, a little bit of wiggle room there. But I think this is going to be important, and we're going to actually move forward and are trying to actually come out with how many active cases are in each community so that actually local community decisions can be more informed. We didn't anticipate the level of interest here. We had 16,000 people hit our website last Friday afternoon when we released this, and we were knocked off the internet for an hour or so before we could try to get back on. So this seems to be a positive contribution. On the next slide, we've got where our cumulative rates, we continue to go up. You've got the number of correctional facilities in orange. Most of the spread now is in the community, and our 7-day rolling averages are up where we're now pretty consistently at the 600 to 700 new cases a day. And just to emphasize, so that's 600 to 700 more people that the health department is trying to do contact tracing and to mitigate their spread. The CDC came out yesterday or day before with a new study where they actually tested antibodies in 10 communities, and their estimate is that the number of people actually infected is probably 10-fold higher than the number that we actually test. So that would put us, if that were true, at about 6,000 new active cases a day, which is not good news. When we look at where we rank on active tests for the states on the next slide, well, these are our active cases on the next slide. When we look at our rolling average, we have been well above the 10% threshold much of the last week to 10 days. And you'll remember that was the threshold that the CDC put out and that the governor used to determine when we would have to start scaling things back. I think we're on this precipice of losing control in some areas again. It's just because the virus is so easily spread, and people frequently are not symptomatic when they have the virus, so that they don't know to stay home and not spread it. That's why the mask issue is so important, to try to reduce that transmission. When you look at our positivity rates, I mentioned on the next slide that Arizona is a hotbed, Florida, Texas. We're up there. We're number 12 out of 50 in our 7-day moving average, and over the last couple of days we dropped down a little bit, but we are, as I said, on that precipice. A new slide that we want to introduce, we're going to have to work on the colors a little bit, but these are the hospitalizations. And rather than looking at every single day, we wanted to do the average number of patients hospitalized on each day of the week, because it shows you the stair step up, the increasing demand on our Arkansas hospitals. Another way to look at that is how long does it take to double? Well, when this first started, it took 44 days to hit 100 hospitalizations. Then it took 51 days when we were shut down and things were pretty quiet to get to 200. It took 18 days to get to 300, and it only took us 12 days to get to 400. And I think we're going to continue to see this demand and pressure on the hospital system. And I just want to go back. This was the reason that we took all of the drastic precautions that we had early on to shut things down. We do have more people on the ventilator on the next slide. We're up now to about 100 folks on the ventilator. I think you hear the hospital administrators want to commit to being able to serve everyone. I think you hear, and they have some backup plans that will help them have some surge capacity. But I think you can see in some communities in Texas and some communities in Arkansas, there is a limit to what that surge capacity can and is available. We'll look on the next slide. This is another way of looking. The number of cases actually is greatest among the younger members of our population. It's the hospitalizations. The number of hospitalizations are actually higher for our younger populations, but those that are older or have more significant comorbidities are ending up having the higher death rates. We have taken the COVID positive patients and looked in the state's all-payer claims database to see which conditions have the worst outcomes. If you have kidney failure and are on dialysis, you have an 80% higher likelihood of being hospitalized, 100% higher likelihood of being in the ICU, 103% on intubation and death. You see these are the likelihood that you are more likely to have these bad outcomes. If you're immunocompromised on chemotherapy, if you have diabetes, COPD, or coronary artery disease. So these are the conditions that lead one to have a greater likelihood of being hospitalized and a poor outcome for the result. I want to keep putting this up here, the quarantine and the isolation advice. I can't tell you how confusing this is to people. It really, it's 14 days regardless of the test if you are exposed to somebody that is known to have COVID-19. This is different than most of the time when you get a negative test, you think, well, I'm okay. That's not the situation. The negative test could be a false negative, and there are frequent false negatives on the front end of the infection. And so that's why the 14-day quarantine is a requirement. Again, if you do have symptoms, you should self-isolate until at least 3 days after your symptoms have resolved and 10 days since you first had symptoms. That's the length of time. We mentioned this before on the next slide. The CDC did come out this week having done an in-depth study of our hair salon up in Missouri, where they did say 2 stylists, they went in to make sure that what was reported by the local health department was accurate, and I think they have put a stamp of approval on that report, that the 2 hairstylists that spent at least 15 minutes, probably much longer, with 139 clients where everyone was wearing face coverings. There are no known clients now after testing that are known to be infected. So this is the best evidence that I have that facial coverings work. I can't imagine a hairstylist treating a client and not having conversation and being in close proximity and really having a close interaction with an individual going forward there. Now I want to re-raise, and we're going to try to do our COVID-19 immunology 101 again. The virus is out there, it's in our communities. The people become infected, but they feel fine. This is that asymptomatic period where they can infect others. She starts to feel sick and her immune system kicks in. This is when you would do the PCR or the molecular test to say, is this person infected? After she starts feeling better, her antibodies go up, first IgM and then IgG. IgM goes up first and then it comes down as IgG goes up later. The open question that we have is, how long does the IgG antibody last? And does it provide us long-term immunity? These are the antibodies that are now being measured in some of the vaccine studies. These are also antibody tests that are starting to come back. One of the reasons I want to go over this is I had one one of our employees has a friend whose son was denied the opportunity to play in the state baseball championship because he had a positive antibody test. Not a positive antigen or a molecular test, but he had a positive antibody test. And so there was a misunderstanding of what a positive antibody test actually relays. It relays that you've had it in the past. The young man had lost his sense of taste and smell a month ago, had been sick, and so he'd gotten a test for the antibodies, and it was positive, and they did not allow him to play. So if we go to the next slide, we've got 3 different types of tests. The molecular, actually looking for pieces of the DNA, diagnose active infection. The rapid antigen is increasingly available in clinics across the state, and it has about an 85% sensitivity, meaning that 15% of the time, if you get a negative, it's a false negative. So if you get a positive, it's good. If you get a negative, you need to follow up with the molecular test. And again, we're starting to have the antibody test from your blood, your serologic tests that show an evidence of past infection. We can go quickly forward in the next 3. The molecular test, this is what we've done mostly. It looks for the genetic material. It's an active infection. These are the names of the tests, and there are 3 sources: commercial labs, well, 4 commercial labs, health department, UAMS, and then some other select hospitals. This is the test that is getting delayed in when it's sent out to the commercial labs. We're having a significant delay on getting back, which then causes a significant delay on contact tracing, which then puts at risk our ability to actually mitigate this in the way that we need. There are increasingly rapid antigen tests. These look for proteins on the virus. They're 15 to 30 minutes. It's a secretion in your nose. It's a little less sensitive. This is where some of that false negative happens. But these are increasingly available in clinics, and I think will help us know if it is positive, it is positive. It's the false negatives that we have to worry about. And then the antibody tests, as I mentioned on the next one, are the serologic tests. They indicate past infections. And we're going to be looking at these to see how long do those antibodies last going forward. Now, some good news on the vaccine front. We've talked about the traditional paradigm that took years, the more rapid, accelerated effort that we have now. If you can click forward, Michael. Now, we now have 2 trials going into phase 3 studies. We have several international studies going forward. If you can go on the next page, there are 3 clinical trials. Actually, we've got 165 vaccines under development. A lot of different things being used, some that are well established, some that have never been approved. We've got 27 worldwide. They're in human trials. This was in the Wall Street Journal yesterday, so I said, wait a minute, I didn't know we had one approved for limited use, so I had to go find where that is. The Chinese Military Medical Academy says that they have a vaccine that they are going to provide part of their Chinese military. So I think I would not want to be one of the Chinese military getting the first dose of the Chinese military medical vaccine that their superior is saying you must take this. So this is where that came from. If we go forward, we've got 5 trials, 2 of which are in the United States. The Sinovac, the Wuhan, the Beijing are in China. The Oxford and the Moderna are going to be available here in the United States. The phase 1 and phase 2 trial results for these are very promising. On the next page, we've not had safety concerns. Now that's a relatively limited number of people, but you start with a smaller number, and now we're going to large scale, 30,000 trials. Participants 18 and older are eligible, and they particularly want high-risk individuals, those that have some of the conditions and might have a higher concern about contracting the virus, and those that are in environmental circumstances that might be more exposed to the virus. We do have the ability for Arkansans to participate. The website there will give you information if you have individuals that want to do that. Now, I want to move now to probably one of the more controversial pieces of information. There is almost a dogma in the political space that we must reopen schools in the fall. And this is at the federal level, it's at the state level. I don't see it as necessarily a political split. Democratic governors and Republican governors are calling for schools to reopen in the fall. So we went to say, all right, what do we know about the evidence? limited though it may be, because most schools worldwide have been closed. But what do we know that can inform this? We do know that children who attend daycare or school are at high risk for transmitting to their family members. A South Korea study, Michael, if you can go forward, the South Korea study, now this was during school closure, that household contacts of infected children older than 10, the infection rate was about 20%. So about 20% of adults in a household with an infected child became infected. It was a little bit less, 5% for kids between 0 and 9. So I think this does show the potential for kids, if infected, to transmit to adults. And when we look at countries that have reopened on the next slide, no country reopened during a period of high prevalence and spread at the levels that we're seeing in our state and the other southern states that we've seen. After schools opened in Germany, Israel, and Sweden, they saw a significant increase in the growth of cases. Denmark and Norway did not. And we've got 8 countries in which school has opened that we don't know the outcome yet. So, unfortunately, the evidence here is a little bit mixed. And I think the important thing is that we need to just accept that if we reopen schools, there is going to be transmission, and we are going to need to take some safeguards as those kids come home to households that have adult individuals at higher risk. Schools will need, and I think many are preparing for this, some are kind of waking up to the new world in which we live, but schools will need to implement distancing, hand hygiene, and mandatory masks. We'll need to know when and how to test students and staff that become exposed, when and how long to require people to stay in quarantine, and when to decide to close or to reopen schools. Some of the strategies that schools are using that I've heard of are that they're actually having students stay in one classroom and having the teachers rotate to avoid the milieu that happens in between periods of the class when all the students come out into the hallway and mill about for 10 minutes as they move to their next classroom. Now, we do have some controversy that is building inside of the state. Yesterday, the Arkansas chapter of the American Academy of Pediatrics, of which I am a member, was not involved in the development or the decision around their statement, said that given the current level of infection, your pediatricians in Arkansas cannot support a statewide return to school decision in August. Their recommendations were fivefold: that local data-driven decisions needed to rule that county level data indicators needed to show that it was safer to open schools, and that's not what we're seeing now. That there would need to be a downward trajectory or a percentage of positive tests that is downward for 14 days, and we're not in that direction. That mandatory masks would be required, social distancing, that schools should be provided protective equipment for staff and for teachers, and also, as we've talked about before, needed to help schools with engineering opportunities to enhance the ventilation that they had. So, we've got concerns. Obviously, there's a need to find the balance. We've got vaccines that are in development but are not going to be here by the end of this month or the end of this year, possibly. So I think we're still in this balancing of the iron triangle, which is we've got to be successful on stopping the spread of the virus. We need our economic well-being to come back. We need to recognize that the masks, although incredibly frustrating, uncomfortable, and I mean, none of us like it, I don't think, but we are going to need to increase our compliance and adherence to that. So with that, let me pause and be glad to have conversation, questions. Appreciate your time and your continued interest.
Ed, I'm going to let you take it over.
Got it. Any questions for Dr. Thompson?
Of course I do.
Sure.
Hello. Okay, well, how are you, Dr. Thompson? Thank you again. I have a couple questions. The first one is, what are the implications of the White House demanding that the data does not be sent to the CDC anymore? Is that
So-
affecting how you guys get information, or are there implications for us being able to see real information, or what do you think?
Let me first say how the information flows to us, and I am not concerned about it being inappropriately restricted right now. I am concerned about the delays in the testing that's going on, causing us to have blind spots for several days before the test results come back. The health department, under its public health emergency, has the authority and has required every COVID-19 test, whether positive or negative, to be reported to the health department. If this is a rapid test done at your provider's office, they have to fax in the results either way. If it's a commercial lab, they have to send those results in. If the health department lab or hospital lab, they send it in.
To the Arkansas Health Department?
To the Arkansas Department of Health. They then put all that data together, and once a week, ACHI, my center, is getting a copy of that data. So I think that data flow is secure. What Sarah's referring to is last week, the White House redirected data that would flow from our health department and hospitals to the CDC. They redirected it to the White House. It was under the guise of an improvement. I think, we all should have concerns that the lead agency that has the intellectual knowledge of how to both analyze and interpret the data is now not in the direct line of the flow of the data. And I think I would have some concerns that, as the areas of the country that have lost control start to have more hospital impact. And I think we may see things like we saw in New York City, in Phoenix, in Houston, in Miami, where, candidly, the capacity of the hospitals were overcome. I hope that information is not delayed in becoming publicly available, but it is a cause for concern, and it's something to watch for.
Okay.
Thompson, toward that question, is there any chance that if there is a perception that if data is being obfuscated, that it could flow through an independent source and get it somewhere else?
I would hope that the political pressure on the White House would be enough not to have to cause a separate channel of information flow. I think, all of our health departments are maximally stressed right now, and they're building things in a way that they can try to optimize information. Having them have to do two things where we could get away with one thing, I think would be an unfortunate step if we had to go that path.
Okay, so thank you. So I have one more question. That's good news that the predicted numbers of active cases in the fall here has gone down.
Correct.
But is that because of like mask mandate, or just how the trends are looking? And does that include schools opening?
So it does include schools opening. I'm looking at my notes here because I had it. I think a large reason for it going down was the plateau and now the slow decline that you all are seeing in Northwest Arkansas. When they did their forecast 2 weeks ago, you may remember, we were on an uphill climb in Northwest Arkansas, which was a heavily populated area. And so that weighted down their model pretty significant, or weighted up their model pretty significantly. So yes, I mean, this week's model, which is built off of cases and projections and assumptions, has us at about 112,000 active infections at the end of October, which is down about 20% from where they were last week. It also, their projections have us, within the plausible availability of ICU beds, ventilators, hospital beds, which is good news. And they do assume a certain level of mask wearing. I don't think that they assume universal mask wearing.
Okay, thank you.
Okay. Any other questions? No? Okay.
Well, thank you all for being on.
I've got a question.
Okay.
So have we seen any research that talks about what is the most effective way for us to sanitize? I know that masks are helping, and through a lot of our different businesses we've been talking to, they've had a different sort of approaches. They've done UV lights. Mm-hmm. I know one of the schools that I used to work with has a halo fog machine, and they actually, I think it's hydrogen peroxide that like fogs into the room and is supposed to sanitize. Is that something that, we're seeing as being effective? Is that something schools should be implementing?
I think the two things that you described, UV light and the halo fogger, you know, those were good sales by somebody to actually provide a hopes for impact. I don't have any evidence to say that those work. I have strong evidence to say, you know, wiping your countertops down with a diluted bleach solution, you know, or commercially available cleaner, that is the most important thing. That plus probably ventilation, if you can optimize your ventilation. And I know we've got some issues in the news about air conditioning and whether that spreads the virus. I think, you know, any closed environment that you have a high traffic area of people is going to have the likelihood for one of those individuals to have an infection. And so that's where I think we're still stuck with some of the same mitigation efforts of hygiene, you know, disinfecting the surface areas, you know, after somebody's been working there, if somebody new's coming in, as we are doing in the restaurants, and then, you know, facial coverings at every time that you can't really make sure that you're different or differentiated in space from somebody else. I will say on the school piece, and this is what my center is pushing for. I hope and I trust that we'll get the health department's support to release it. You know, those community level numbers that we released earlier, that was the total number of cases up to this point in time that a community has had. We're working diligently to try to get the active number of cases that a community has today, so that hopefully by the time school starts, we might have 2 or 3 points in time of active cases for communities, so that they would be able to know, is their trend line going up? Is their trend line going down? So that local school officials might have a little more granular information to make decisions and to help both assure staff and parents that it is indeed safe to go back to school. I am worried though that we're not seeing, if the CDC's study that they put out yesterday, having tested antibodies in those 10 larger cities, found that they basically missed 90% of the cases. You know, if we've got 6,000 active cases that we know about, if you apply the numbers, we have 60,000 active cases out there in total. Now, I'm hopeful that Arkansas, because we're rural, because we're spread out, we're not like those 10 cities. I hope it's not a 10-fold increase, but there are more people out there that have it than have been tested. Yes, sir. Go ahead, Bruce.
Appreciate that. Dr. Thompson still working on that 24-hour virtual line.
Let me know when it is. I'll either be the first or the last through the line, whichever one you want me to be.
Yeah, let me, if I could, let me play a bit of devil's advocate on that. It is a virus, and I'm personally skeptical of a very effective vaccine, even with all the energy that's put, more so than the last 100 years. So is there some positive that can be seen if there is 10 or 20x of the number of people that have been exposed to a virus? Because by a virus by nature, you're going to be exposed to it. And so can you speak a little bit about that? And I know it's a tough call in your position, especially.
Well, and let me just frame it. I think I'm sensing right now they're kind of maybe 2 or 3 different mindsets. There's one mindset that, you know, we should shut down and shelter down until we have a vaccine. And I share your concerns a little bit that, you know, we're putting all our eggs in a vaccine basket here. And I think there are promises. This is a virus, you know, in a family of viruses that we have had successful vaccines before. We are putting a lot of resources into it. The early trials do look positive. It's a big open question for me is how long will the protection last, you know, at that point in time. So there's one group of folks saying, let's shelter down and wait for the vaccine. The opposite end are people that are saying, let's just bulldoze through and get this over with because everybody's going to get it sooner or later. And I think the middle group, which is where I find myself, is, you know, I think we are going to have a slow burn on this. Our bodies have never seen this virus before, so there is going to be, you know, a continued escalation of the number of people that have been infected by this, because it didn't go away with summer. It's going to get worse with winter, you know, and this is going to be with us. The 1918 virus was here for 3 years, and the death rate was higher in the second year than it was in the first year. And then it started to come down in the third year. So I think there is a natural recognition that this virus is novel and that at some point we're all going to need protection from it, either through having had the virus or having gotten a vaccine. I think the reason to stay in the middle here is really because we are learning more about how to treat this virus. We're learning more about how this virus attacks us, about who is most at risk for this virus, who, when we have a vaccine, should get it first because they have the highest risk. So I do think having precautions, keeping this top of mind, trying to slow its spread as much as possible is the right course to take. I think we will have harm if we have to go back to where we were in April and May, and we will lose lives that are salvageable if we just bulldoze through and say, you know, it doesn't matter what we do.
I had a question, Dr. Thompson.
Sure.
Something I've been curious about, does the viral load that a patient gets initially have anything to do with the severity of the illness they have? So for example, if someone sneezed in front of your face without a mask versus you speaking with someone for 5 minutes at a bar without a mask and just getting it from their breath, does that affect it, or just once the virus is in your body, does it start replicating on its own?
So great question, and I'm going to answer in two parts. I think the viral load that you are exposed to, okay, at the point of time that you get infected probably has more of an effect of how quickly you're going to develop symptoms if you develop symptoms, right? If you end up with a small exposure, the virus has to replicate for a longer period of time, and you'll have a symptom onset that is later in the course of illness, as opposed to if you get a huge load early on, you gave the virus a head start on your 5K race with the COVID. I don't think there's evidence yet, and I think folks are studying this, about whether the severity of outcomes of illness is related to the viral load. The virus replicates when it does take off, it takes off exponentially. And so when folks are sick, they really do have, a high viral load. You can also have a high viral load and be asymptomatic. That's for the asymptomatic but infectious folks that are out there. I have not seen anything about viral load being correlated necessarily with the severity of disease. I think it's more correlated with some of the conditions people have that make their body less able to respond and combat the virus when they do get it.
Okay, thank you. And then one more question. You said the Spanish flu in 1918 went away after 3 years. What eventually made it go away? I mean, did it just disappear, or did the humans become immune to it?
Well, a lot of the humans didn't live through it, but it did spread, and it was worldwide. And I think either enough humans became immune to it that we ended up with herd immunity, so that some individuals still got it, but it didn't spread like wildfire. You had enough people had it that it didn't spread, or the flu virus migrated to a less severe version, in those later years, and it became less of an impact on humanity.
Okay, thank you.
Any other questions? Dr. Thompson, thank you all for what you do. You do such a tremendous job of aggregating and interpreting this data and giving it to us with calm and good mix of calm and caution. And
we'll try to stay on top. I had a few more slides than normal today, but we got a lot of moving parts here that I felt like were important to put out for your viewership.
We'll take and appreciate everything you give us.
All right, thank you all. Have a good week. Stay safe.
Thank you, Dr. Thompson.
I would encourage you, and again, we are moving the battle line on this. People are recognizing it's a threat and taking more precautions. But if you think about, just writing down on a piece of paper why it's important when you go into a business for that business to be protecting you. And if they're not, you don't have to have a conversation, but hand them the piece of paper and say, I'm leaving because I don't feel like you're protecting my health. And I think your leadership voices are important in the community to provide those business leaders reinforcement and support for doing the right thing. And so with that, let me sign off and thank you all. Have a great day.
Thank you all. Appreciate it, Dr. Thompson.
Thanks.
Anybody have anything they'd like to share while we're all here? Yeah. Reese, you're making some tough decisions. I saw, saw the news about the Joe Martin event. So there's something you to do.
I told somebody that my samurai sword, when I get to wield it again, it's going to be as sharp as it can. My toolbox is I've got so many more tools. And so, we're just trying to be creative and stay there. You know, one thing, because this is a business discussion, if there's a banker here, I heard that last month, 12 million individuals missed a mortgage or rent payment. And that seemed to be, that wasn't, I saw it. So that's really disconcerting, because, it's affecting the lower half of the population.
Yeah.
Economically, I don't know if there's an answer.
No, there's just tough, no-win decisions, having to be made almost every day, right?
Yeah.
You guys still looking at the Big Dam Bridge ride?
That's, I don't want
to put you on the spot.
We're trying to be very creative. If 3,500 people, September 26th in Arkansas, that's going to be a tough lift for the brand, for sponsors, for people, community. We're coming up, we're 3 weeks away from making the decision. If I was a betting person today, I would believe that's going to go virtual. I kept hoping that, there would be a burnout. But you got to be realistic, and you got to, it's a bigger picture than just.
I hate that. I've ridden it the last few years. It's a great event, So.
We'll be back.
Good.
No, regardless.
I'm a member, but I was not.
Good. Anybody else have anything they'd like to share? Well, Tommy, everything going all right in your world? I don't know if he's.
You hear me?
Yes, sir.
Okay. We're still on track with our budget as far as income, etc. So we're pleased with that, and that will continue for the next 3 months or so. But we do see, at least at our company, we're seeing probably a little bit of a downward trend on income and transactions for the fourth quarter, just as things kind of burn off that we've already been working on, and it'll end up, it's just going to get slower because transactions are going to be slower with COVID, and companies, really nervous about making decisions, and they're worried that, they just don't know what it's going to be like on the other side. So we're not seeing a big change in demand for office space, as far as companies trying to reduce, have more people work from home, and it's that hasn't really happened yet. I do feel like it can be a factor in the future, because even in our company, we look around at how many folks are working from home or working a couple of days a week in the office for 4 hours or something, and we look at our overhead and rent, and we can do with less, but we don't know how long that's going to feel good, so to speak. I think everybody does want to be back in the office as a group, but at the same time, some people are enjoying working from home, being with family and being able to be more flexible. So, there's a lot going on right now, and I don't think any of us are smart enough to know what it's going to look like from an office standpoint. Retail, restaurants, and retail are still really hurting, and if there's not more stimulus that's going to happen with regard to mainly restaurants, and I'm talking about locally owned restaurants. It's going to be tough on them. The warehouse side of our business is strong. Demand is strong. Apartments, multifamily is strong. Land sales are slow because of uncertainty and companies not wanting to build and expand. So I think that's it.
Well, appreciate that report. You keep yourself healthy, okay?
I'm doing it.
Well, appreciate you.
All right.
We had Stuart Walker, who owns Clubhouse Fitness, is one of our forum members, and he was providing us with a really, really interesting perspective. We may try to get Stuart on here in a couple of weeks or so, just to get that, because very, very interesting perspective that I hadn't considered. Well, before I call it, anybody else want to share anything? Well, thank you all so much for joining. We'll have another one of these in a couple of weeks. Hopefully good news will continue. So we appreciate you joining us, and I think Tim's got some guests lined up for 2 weeks from now. So stay tuned, and we'll see you then.
Thank you, Ed.
Okay. Thank y'all.
Thanks,
guys. Thanks, Caitlin, for what you do.
Thanks, guys. We'll see you soon.